Good afternoon, everyone. Just a reminder, this meeting will be recorded. So if you want to be off camera, that is completely understandable. It is 2 o'clock. We'll plan to start at 2:02. We'll let those that are joining us finish coming in. Okay, I'm going to go ahead and share my screen. I think the lobby has slowed down some, so we'll go ahead and get started. Welcome, and thank you everyone for joining us this afternoon for a public workshop on proposed edits to policy MSM Chapter 4100. My name is Beth Scott. I'm a policy specialist for substance use treatment in the Behavioral Health Benefits Coverage Unit with Division of Healthcare Financing and Policy. Today's meeting, just a reminder, today's meeting is being recorded and will be available for viewing. I want to extend my gratitude for your participation as I know everyone is very busy. Your voice in today's discussion is appreciated and valued as we work through some policy changes to ensure clear, concise, and sensible edits. The purpose of this workshop is to discuss proposed changes to Medicaid Service Manual MSM Chapter 4100, Substance Use Disorder Treatment Services. Therefore, we're going to clarify some service descriptions for residential substance use disorder treatment ASAM levels 3.1, 3.5, and 3.7 WM. We're going to review, yes?
Can I just pause? I don't know if you're sharing
Sure.
your screen or if you think you're sharing your
Oh, I
screen, but I
thought I
don't see
was.
anything.
No. Okay. Oh, I hit the button and forgot to share. Okay. Thank you, Marcel.
There it is. Thank you.
Mm-hmm. Okay. All right. Okay, well, take two. Thank you Thank you everyone for your patience. Welcome and thank you for joining us this afternoon. My name is Beth Scott. This is a public workshop to discuss proposed edits to MSM Chapter 4100. Today, during this public workshop, we're going to discuss proposed changes to Medicaid Service Manual MSM Chapter 4100. Therefore, we're going to clarify the service descriptions for residential substance use disorder treatment, ASAM levels 3.1, 3.5, and 3.7. We're going to review and discuss proposed changes to progress note requirements for non-clinical structured activities within residential SUD treatment settings. Next, we'll review proposed language that will change the requirement of when a psychiatric evaluation is needed. And lastly, we'll review a proposed requirement for substance use treatment providers to enroll with separate NPI who qualify for more than one substance use treatment group specialty. ASAM level of care 3.1. Language is being added to policy section 4106C1.A4 for ASAM residential SUD treatment service level 3.1 that clarifies in order to be reimbursed for the daily bundled rate, Daily activity must be provided that aligns with the individual's treatment plan goals and that the program must be in compliance with criteria set by the Division of Public and Behavioral Health. For ASAM level of care 3.5, language is being added to policy section 4106C1.B5 for ASAM residential substance use treatment service level 3.5, which clarifies the description of service hours within this level of care and clarifies that in order to be reimbursed for the daily bundled rate, daily activity must be provided that aligns with the individual's treatment plan goals and that the program must be in compliance with criteria set by the Division of Public and Behavioral Health. Next, language is being added to section 4106C1.C3 for ASAM residential substance use treatment services, which clarifies that in order to be reimbursed for the daily bundled rate, daily activities must be provided that align with individuals' treatment plan goals, and the program must be in compliance with criteria set by the Division of Public and Behavioral Health. And for this section, lastly, policy section 4107A5B.4 requires a psychiatric evaluation to be completed. Proposed language is being added that would now require a psychiatric evaluation to be completed when clinically indicated. These proposed edits to the language for ASAM levels 3.1, 3.5, and 3.7 WM came out of our last monthly provider substance use disorder call, where there were concerns about the lack of clarification of what those services look like. So before we move on to our next topic, the new things that we need to move on and talk about, I just want to take a moment to pause here to see if there's any questions, comments, or feedback about changes to the residential substance use disorder services. Okay. Okay.
Beth?
Up next, oh, sorry.
Oh,
I'm
there's a
sorry, I was trying
couple
to raise my
hands.
hand. I didn't think you saw
Oh, I can't see hands. I'm sorry.
Oh,
I was curious about the policy 4103 about the different MPIs. Can we break that down a little bit and how that's supposed to look? Are you talking about
We'll
different group MPIs or different?
we'll Brandon, we'll get there in a moment. That one
Oh,
is that is new proposed language. So we will definitely get there, I promise.
oh, okay, okay. Thank you.
You're welcome. Hang on to your questions though. I'm sure they're good ones.
and we have
Okay.
one more hand up from Jennifer.
Okay, Jennifer.
Maybe she put it down. Maybe she's
Okay.
going to wait.
Okay. Okay.
Sorry, I forgot to unmute myself.
Oh, sorry. Go ahead, Jennifer.
So with the psychiatric evaluation, is that just in withdrawal management, or is that like 3.1 and 3.5 as well?
In policy, I would have to go back and review in policy where it is. I believe it was the inpatient psychiatric.
Okay.
I think it was the 3.7 WM, Jennifer, but I apologize. I would have to pull. Oh,
Okay.
I need to pull that up. I'm sorry. I can't. Okay.
Not sure if Beth, you wanted it. I dropped your 4100 in the chat just for quick reference if you
Okay.
needed it
Thank you,
or anyone
Marcel.
needed it.
Okay. Up next, we'll discuss progress notes. DHCFP has had several conversations with our substance use providers and received many questions about the ability to perform and be reimbursed for appropriate non-clinical structured activities that are facilitated by people who are non-licensed individuals. Additionally, DHCFP received a lot of feedback about fraud concerns that the rendering provided listed on the claims wasn't necessarily the person who was going to be facilitating treatment. It was never the intent of DHCFP to take away these beneficial services from recipients. DHCFP and CASAT came to the table to discuss how best to move forward to ensure that the recipients are getting what they need, that the providers can be reimbursed for appropriate services rendered, and documentation matches claim submissions. As a result, policy section 4115B is being updated to add language about progress note requirements. The text in red was originally proposed in the posted online version of this PowerPoint, but after further discussion with CASAT, DHCFP would like to propose the above text in blue, and we would like to discuss this further with your feedback. The new language proposed states that the lead clinician is required to do a sample of records monthly as required by the certifying body through the Division of Public Behavioral Health. And this is where you come in. DHCFP has some questions for you, our providers, about this proposed documentation change. We would like to specifically know if this change addresses your concerns adequately, if there are barriers that this change imposes within your settings, and what are the benefits of this change within your setting.
Beth, I have a question from Jennifer in the chat. She's asking, can you define the structured activities?
Sure. I don't have, so the structured activities within your group, that's ASAM language. Mark, can you speak to this a little bit for us, what we're talking about? We're talking about the structured activities within levels 3.5 specifically, where the policy says that in 3.5, 25 hours of structured activities need to be provided per week, 10 of which need to be group therapy or individual therapy. So the structured activities are any part of that program, right, Mark, that was set up by the master's level clinician?
Yes. So in the ASAM third edition, it provided like a kind of a laundry list of different activities that are part of structured. In the fourth edition, they kind of went a little more general. But structured activities would be, obviously 10 of those would be group and or individual counseling, which is consistent with current division criteria for a residential treatment program. This is a 3.5 residential treatment program. And then the other structured activities would be things like psychoeducational groups. It could be recreational therapy that is structured. It could even be PSR and VST if it was clinically indicated and beneficial to the client. So, and to kind of talk about what would not be a structured activity that would count towards the 25 hours, but a program could do, a 3-point program could do, that would be such things as some of our residential treatment programs do AA groups, NA groups. That's fine, but that would not go towards the 25 hours of structured activity. Also, skill building groups would be part of those structured activities too. So individuals, staffing that do some of those types of services, obviously they may not necessarily be certified or licensed, but they're very much part of the treatment below. This would be things like detox technician, a mental health technician. Often residential treatment programs rely on those folks to do some of the other structured activities beyond the clinical work. Does that help?
That helps me. Thank you, Mark. Jennifer, does that help answer your question? Okay, Thank you. Jennifer, I also wanted to go back to your question about the psychiatric evaluation, and I just am going to pull up policy to share with you where that lives currently and what the whole sentence says. A psychiatric evaluation must be completed within 72 hours of any inpatient withdrawal management or treatment admission, and that is where we're adding language where it will say when clinically indicated. Yep. Thank you, Teresa. What about outside community providers providing groups or services to clients under 3.5?
Are these like voluntary individuals coming in and doing structured activities, or are these people you contract and pay to come in to do some under your roof in your program activities?
This is Angela Westcare is my question, and it's mainly those that volunteer.
And what would the activity be?
Like some of them do spiritual care groups, wellness groups, those kind of things for our clients once in a while.
And you would want that to be part of your 25 hours?
Yeah, well, yeah, I'm asking if it would qualify or not. I'm building a yes and no list.
I mean, at the end of the day, you're getting a daily rate for the milieu of services. So the question is, we would have to look at the specific individual activities and groups that are being provided, whether they're volunteers or not. I'm not sure if that would matter to Medicaid. That's more of a Medicaid question on that. I guess the only potential concern is that if that's being overutilized, what kind of quality assurance measurements do you have in place? And ultimately, Medicaid's paying you to pay staff to be able to deliver those 25 hours of services. So if volunteers are overly utilized, then I can see that could be a potential issue. I'll give you an example. When I used to do IOP in Las Vegas back in the 90s, I would have like the Southern Nevada Health District come in and do HIV testing and then counseling, but I was always in the room and very much a part of that. But it was only like 1 hour a month, right? So it wasn't a lot. And of course, back then we weren't reimbursed for IOP under Medicaid. That was just good old block grant dollars back in those days. So I'm not sure if that's something that Beth, you would want to bring back to further discuss the nuances of that.
I think yes, we're going to have to, because I wish PT 93 was created, right? So that we would know with the biller and the renderer in mind. And so under provider type 93, being able to determine who's providing that service was the goal, right? Of having people enroll that way.
Yeah, and I'll add to it because I was involved early on in the waiver, and one of the ways the cost of providing services was just to look at the staffing that was going to be required to do that, and so that was all built into the cost, and I think that flows back to the daily rate.
To the increased rate.
Yeah.
Okay.
Can I just add on to the same discussion? So we have like community partners, let's say like the Domestic Violence Resource Center, and they come and do weekly like DV education type groups for our clients because 95% of our clients have DV in their history. We have somebody who comes and does like trauma yoga, different things like that, not just like, anybody kind of who says, oh, I really enjoy your program, I want to come teach a group about, XYZ. They're all related to kind of what the clients are in need of and what's on their treatment plans and things like that.
Do you have a paid staff person that's a part of those types of groups?
Like that sits in on those groups?
Correct.
No.
Okay. That's just a clarifying question. I'm not sure what that means. That just came to mind.
Yeah.
I think trauma yoga is one thing, but domestic violence, I think that it's important to have a clinician in those groups as well, for a lot of different reasons. You're turning over a structured activity to an outside provider, and you really need to have a clinician in there to see how the clients are responding to that, because ultimately the clinician is going to have to do coordinated care above and beyond the domestic violence person coming in and doing that. So
thank you for clarifying, Mark. I see the question in the chat about it being helpful to have in policy what structured activity a definition would be, help to prevent this from turning into issues from audits. I think probably the next slide where we talk about progress notes. Hold on a second. When DHCFP and CASAT came to the table to talk about how would we document this, let me take a breath. We all know that the programs have to be certified through SAPTA, right? And SAPTA has the overview. DPBH has the oversight of the agencies. So they're providing the certification. They're going out, they're doing site visits. You guys are reviewing records, making sure the right people are in the right place, performing the right treatment. So that's kind of the lens that we're coming from, right? And so the question from the last time this group got together, where we were talking about, there were going to be concerns for the audits that came up, was, okay, how do we prevent that? How do we help prevent that from happening? And so CASAT's recommendation was the text in blue after we spoke about it, is the lead clinician being required to do a sample of records monthly as required by Division of Public and Behavioral Health currently. And so our hope is, and I'm going to stop sharing so I can see and actually not talk to my PowerPoint. The thought was, I switched screens and forgot where I was at. So the thought behind that is, if your progress notes are already being reviewed and it's being reviewed through CASAT, and this has been, I ran this by SIR to see if they had a problem with this language too. Does that help alleviate some of the concern about audits?
Can you give a little bit more detail about what you mean by a monthly sample of records?
I can give clarification. Basically, that's part of your quality assurance process. Providers already through SAP certification are supposed to be doing, monthly to regular. It doesn't necessarily have to be monthly, but at least quarterly review of, clinical record documentation. And so usually it's the clinical director or their designee that would be doing regular review of, is the assessment appropriate? Is the DSM-5-TR diagnosis substantiated? Is the treatment plan, person-centered, behavioral and symptom-driven, tying back to the DSM, and then progress notes. Are the progress notes meeting the minimum standard as well? So, and usually a way to do quality assurance is that the clinical director looks at a sample of records on a monthly, bi-monthly, quarterly basis to see that all of that stuff is appropriate. And so really what we're talking about, I think in light of this particular issue is that if a non-clinician is doing a psychoeducational group or a skills-based group and they do a progress note, that the clinical director is reviewing those progress notes to make sure that they are accurately reflecting what's going on, and that, obviously the clinician's clinician is, I mean, not the clinician, the staff person, for example, a detox tech or a mental health tech, is working within their scope of practice. So that regular review is just really part of your quality assurance process.
Okay, so we definitely do that. So if, like, let's say the group note in our system is put in and it's by like a non-clinical provider, and the clinic and our clinical supervisor goes in, reviews it, and signs off on it, so then we have 2 signatures on that note, would that suffice?
Well, that would be doing above and beyond what we're requiring here. That was the original thing, that every progress note by a non-clinician would be reviewed and signed off on. But we had proposed that might be too labor intensive for the clinical director to do that. So, or their designee. So by making it part of your quality assurance plan and review of that, at least you're looking at a sample to make sure that those notes are appropriate. But if you want to go above and beyond and review every progress note by a non-clinician and sign off on it, I think that is going above and beyond. Would you agree with that, Beth?
That was a consensus of what we came to. That way we could continue to focus on treatment happening in the agency, because part of the certification process with SAPTA is that the program is already reviewed for appropriateness and necessity, right? So I'm sorry, I mean clinical appropriateness. And because that's already, I mean, through DPBH, it's already been determined that the services you want to provide that are appropriate and that you have the right people in place to be able to perform those services. And so, Jennifer, instead of the state taking the stance of every progress note needs to be signed, SAPTA is already reviewing your progress notes. We wanted to be able to piggyback off of the efforts that are already being done and not create more burden on the providers.
Thank you. That helps clarify it. So basically just writing into our policy that these quality assurances are happening and how frequently, and then being able to have some sort of documentation to support that.
Correct. And that's something we would review during a SAPTA certification review. And then going back to the structured activities, really, like I said, the ASAM 4th edition has been more broad in their description versus the 3rd, but skill-based groups like relapse prevention, group and individual, which is the 10 hours, that's pretty straightforward. That's done by a clinician. Psychoeducational groups, again, PSR and BST could also be a part of that. Obviously, it's part of the daily rate, so you couldn't bill for PSR and BST above and beyond what the daily rate is, but it could be part of your residential treatment program. And if you look at the 3rd edition of ASAM, they actually list PSR in there, and then they removed it in the 4th edition. So if you over define structured activity, then it may exclude some potential structured activities that would be appropriate, right? So forth and so on. Because you can have like more formal recreational therapy that could be a part of the structured activity, whereas versus, oh, you guys, you may go out and, play some basketball or whatever. It's non-structured recreational versus structure where you have somebody that's actually leading it, and and there's something more edifying to it, more
right.
That kind of stuff.
So watching TV, nap time, and bedtime, those are not activities that we're looking at. They're not therapeutic. Those would not be considered activities that we would reimburse for the daily rate. So this is why the intent of recreating, especially for 3.5, was out of the desire to clarify what that looked like, not to create more confusion. So if I've created more confusion, I apologize, but that's why I wanted to have a public workshop and get feedback. And Mark, I really appreciate that you're here to be able to help us through this as well.
Great. I'm glad I'm here. The other thing, can I just add one other thing? Job training, GED prep, those are other structured activities that are very important to somebody in a residential treatment program. Just to give you a couple more ideas.
Right. It would be the treatment and services that are appropriate for the populations for which you're serving, that you're treating. Brandon, go ahead.
So I was just trying to play it out and kind of how it looks, from beginning to end, documentation all the way even to billing, right? Because, these used to be under PT-17s where services were billed under the group. Now there's individual providers are linked, so you're kind of using their individual MPI. In a service like this where it's residential, are we using the clinical director's NPI then as the rendering when we're billing residential?
It is the person, yes, it would be the lead clinician who has oversight of treatment for that recipient. That would be the person that would that's enrolled with Medicaid that would be responsible for treatment for that recipient.
Okay. So then under that daily rate, then we're also saying there's these other structured non-clinical activities that are provided, right? That might be provided by a peer specialist or a BST, a PSR, another agency coming in doing educational workshops and things like that. And are we saying that these need to be listed as these activities, or that each activity that is done needs a progress note?
If it's a structured activity, you know, there should be some kind of note about person participated in this structured activity, and so forth and so on. And Brandon, thanks for bringing up peer recovery support services, because I should have added that in there along with PSR and BST. And definitely when a peer support specialist does a structured activity by Medicaid, they have to document that unit. I'm not so sure about like recreational therapy. That's something that maybe we need to look at a little more closely, because that might be a little hard to write a progress note for that. But psychoeducational and skill-based groups, I believe a progress note would need to be done for those types of activities.
Okay. And then when we're talking about signing off on that progress note, is it the person that ran that activity, or is it the person that's basically supervising the activity, like the clinical director or a clinician?
It would be the person supervisor if you chose to go with the sign every note.
Right.
Which is not what we're
the document in the chart should be, I'm not telling you to falsify your documentation, right? So if I'm Mark's supervisor and we're employees of your agency and Mark is facilitating the group or the activity, then Mark would have to enter the progress note. But I could pull Mark's note to co-sign because I have oversight of that. I am the clinical supervisor in that situation.
And maybe that's how you show that supervision was done, that you're keeping an eye on what Mark did in his group for activity or recreational or whatever it was, right? That it was appropriate, right? So maybe you're signing off on it, or maybe you're signing a daily log or something. I don't know. I guess it's how the program is approved through SAPTA. But my concern would be then when the billing, because let's say Mark's doing the recreational activity or the non-structured, non-clinical, let me just say non-clinical activity, and you're the clinician, maybe you're seeing another patient doing some other kind of therapeutic activity right then, right?
Right.
So you potentially have the situation where there's multiple billing going in under your MPI as that clinical or that clinician at the same time, I guess. No, well, I don't, you're just signing Brandon, 2 notes at the same time.
It's a daily rate, so the rate's going to be the same. So you're not like billing for individual services. You're billing a daily rate for in the lieu of services. So that's not really going to be an issue.
Okay, I'm thinking of facilities kind of billing this under this lead clinician, and then that lead clinician can be doing other things technically at that specific time.
Of course,
that day,
Yes,
so you guys are going to see multiple things under that person's MPI potentially come in under the same day, I guess,
No, there should be it's a daily rate. So you should only see, like Mark was saying, you should only see one claim per day per recipient.
Right, but that doesn't mean that clinician isn't doing something else somewhere else, or
well, the clinician by co-signing, I'm not saying that I was providing treatment, right? Yeah, I'm saying that I'm acknowledging that the services that were provided were clinically necessary and appropriate.
So I just want to acknowledge that, because in the system, when it comes out in the back end, it could potentially look different, right?
Right, and I think that was the concern of I think that's why there was some clarification about why this discussion of 3.5 came up from the last time that we got together as well, is because there was some concern that there were going to be red flags for audits. Angela, you have your hand up. I know that you may be able to have something to
segued
add.
right into it. So Brandon, I'm glad you brought up, I oversee all the billing for our organization. So what we had to do was we actually had to build an entire new progress notes documentation structure so that all of these services that are provided are put into one note, because it has to trigger a 1 unit note. And I'm still concerned in an audit because I've had the MCOs tell me flat out that if we bill everything under one person, it's going to trigger an audit. So I still have the concerns, being that we're billing a per diem rate under a person, and it has to go under one person, because if you have it under several people, you'll have hundreds and hundreds of claims that I've already kind of been told by the MCOs that they don't like it and it's going to trigger an audit. So a lot of the questions about, what you guys would look for in an audit, or the third department, Elizabeth, thank you for checking with them, is what are they expecting to see? So that's why, I wanted to know what a structured activity is. Do you need to see all the separate things done as separate services? Or can you see one note where we capture everything based on our schedule? Because we had to try to find something that was not an overburden to all of the clinicians that now have to document every single thing every single day, when everything's going to roll into one person frame.
Yeah, that's what I was trying to say, is like, I think it's still kind of an issue, at the end of the day when it comes to the billing. But I do see, like, there's possible, like you said, it's almost like a daily activity log, and then, yeah, but at the end of the day, somebody's signing off on that, and if it's going to be the clinical, most likely because it's being under their MPI, because it's not under the group anymore, I think it's still that issue is still there.
I appreciate the conversation and bringing the concerns forward. I don't have an answer nor any feedback about how to change that at this time, but more so of how do we prevent. I wanted to have for this further discussion to know does this address that issue to prevent those potential audits, because that's a way. I mean, I don't want any. That's not our intention, is to increase that risk for anybody. So. Please continue to bring those questions forward, especially if they turn into issues and they're not a hypothetical situation. Bring that information forward so that we can address it. That would be my ask.
Just brainstorming a possible solution. Again, it makes me almost think that you're looking back at a billing under a group MPI when it's residential versus an independent clinician.
That question has been raised, and I don't have a solution for that. I know that I believe that there are discussions that are happening that I am not a part of those discussions, but the question has been raised. The state has heard that concern. And fortunately, right now, there's no change implemented for that, but the issue has been raised and is being considered. Okay. Okay, so Brandon, you asked about moving on then from progress notes. For the sake of time, if we have other questions, please email the behavioral health inbox or reach out to me directly. So something that's new to this group is this unique NPIs. So what we have found through the early enrollments of provider type 93 is that we inadvertently enrolled individuals or groups incorrectly. So I don't even know what to say to this. We have some IMDs that should be enrolled as 704s that are not. They're enrolled as 703s, and that's because both IMDs and non-IMDs could perform the residential services. There's nothing in the system that blocks that from happening at this point, and it wasn't something that we didn't realize until after the fact. Because the IMD was a part of the 1115 waiver, there are CMS requirements associated for that. in order to get the adequate and correct information for CMS, we had to ensure that providers are enrolled correctly. So the state's fix for that is now, if you are going to meet, if a group enrollment qualifies for more than one substance use group, I'm sorry, I lost my train of thought. And you're SAPTA certified to perform treatment services, then at a level 3 and a level 3.1, I'm sorry, not 3.1, a level 1 or a level 2.1 or 2.5. So you're doing outpatient or IOP or PHP and residential services, then it's going to really rely on your bed count. If you meet the definition of IMD, you're going to need to enroll in both with 2 separate MPIs. You'll need to enroll as a 93704, which is the IMD residential providers, and you'll need to enroll with a separate MPI as a 93707 to be able to capture your outpatient, your IOP, and your PHP services. So that there is on the Nevada Medicaid website, next to the group enrollment checklist, there is a new document that was just posted in the last couple of days that is kind of a flow chart, if you will. Sarah put it together. She did a great job. That it's a flow chart, if you will, about when you should, to offer that guidance of when you should apply for as a 704 and when you should apply as a 707. For clarification, and this is very clear throughout the rest of the PowerPoint, the definition of IMD is not changing. So that is in policy, that is a CMS definition, that's not changing. But so for what we're saying, right, is if your bed count is 17 or higher, and because an IMD, right, an IMD is if your bed counts are 16 or more, right? So if you have more than 16 beds and you are SAPTA certified to perform outpatient services and level 3 residential SUD services, you will need to enroll as a 93707 and a 93704 with separate MPIs so that the state can pull data as required by CMS. It's a way that in order to get the accurate data, we need to make sure that everyone's enrolled properly. So I'm going to pause there because this is new, and I know that there's probably questions. Brandon, go ahead.
Okay, so if I'm understanding this correctly, if it's residential, that needs to be one provider type. Even if you do both different levels of residential, each one would need a.
It depends on your bed count, right? Because IMD
Okay.
is specifically your bed count. So if you have 17 beds and you're SAPTA certified for residential services, and you also want to perform, let's say, IOP and PHP, right? You need to, at that point, do 2 enrollments with 2 MPIs. You need a 93707. Because remember, as a 93707, you can do outpatient and residential, right? That's your non-IMD services. And then you would also then have to enroll as 93704 if your bed count is 16 or less, or 93704 if your bed count is 17 or more. So if you're an IMD and you're SAPTA certified to perform outpatient and residential services, you need to enroll accordingly.
Okay, good. I was worried at first it was going to be a different MPI per service.
No, not per service.
All the, but okay, it's just for like the lower level ones, all inclusive kind of thing, and then the higher IMD, or if you have more beds, it has to have a separate MPI.
Correct, because your IMDs with a higher number of beds, right, more than 16 beds, they can only do residential treatment. So if that's all you want to do is residential treatment and you have more than 16 beds, great, then you're a 704, right? Mm-hmm. But if you are going to provide any of those outpatient treatments and in addition to the residential services with the bed count, because that's the important factor here, then you would also need to enroll as a 707.
Okay.
For clarification, I just wanted to, it's just informational. It's not changing. The definition isn't changing, but I just wanted to point out in policy, it's in section 4108. If you needed to look in policy to be reminded or kind of needed a refresher of what that definition is, it lives in 4100 at section 4108. And the hinge pinch or the determining factor is the 16 beds or more. Jennifer, go ahead.
Okay, so step 2 has a 20-bed residential facility. And so if I'm correct, I think we're enrolled in 707 right now. But we also offer outpatient, which is level 1, and IOP level 2.1. So we need to also apply for the 704.
Where is Jennifer? I have that report. I don't have it pulled up, but I do have. There are a couple that we haven't. There's been no movement on what to do with them, but I think there are 4 providers that are enrolled as a 707, and they should be a 704. Oh, Susan's online with us. Thank you, Susan. Go ahead.
I don't want to call anybody out or call out groups that might have to that fall into this category. But if you are enrolled as a 707, that's your 17-215 equivalent, more or less. So your levels 1, 2.1, 2.5, and level 3 under 17 beds or under 16 beds. That is going to be your 707, and then you would enroll with the different ASAM levels of care. If you have greater than 17 beds and you're still doing level 1, 2.1, 2.5, then you would also want to enroll as a 704. But I don't know if we've provided any type of guidance as to what providers should be doing if they do need to, in fact, have that second specialty. I know we have a couple of providers that are working on getting enrolled that way, but it didn't get discovered really and confirmed until the last couple of weeks. So I'm going to let you take over after that, but that's kind of the clarification there.
Thank you, Susan. You gave me enough time to pull up my chart too, so that I could refresh my memory. And yes, that's what I was going to say. That I'm not going to call out agencies individually. So thank you, Susan, for providing that clarification. And yes, the codes that are in there, if your billing is going through, not quite sure how to move forward with it, but if you're enrolled and everything's going through, you're good. We did this on a go forward basis. So that's where we are right now, Jennifer. I don't know if that was a broad answer to answer your question, but if you have additional questions specifically, Jennifer, please reach out to us. Okay. Brenda, go ahead.
Just quick, the piggyback off of this then, does that mean we also have to have a different tax ID or not if it's a different MPI and a different registration?
I'm gonna.
That is not required. So we're not requiring it's a different tax ID because it's still the same entity, it's still the same agency more or less, or different locations if sometimes that happens. But the tax ID does not have to be separate. It's just the NPI.
Okay. And then I'm also thinking about I'm curious what the MCOs will say about that, you know what I mean, and what their perspective on, because then we also have to enroll with them in a mirror kind of way, correct?
You mean about the separate MPIs?
Right. So when we go to the MCO and we're enrolling our program, if they have to, I don't even know, this might even not affect the majority. It's probably a select few, but again, I just, since we're bringing it out as a work group discussion, I was just proposing the question, and how the MCOs would view it, and would it be 2 separate enrollments with them as well?
Listen, I appreciate the questions because that's where change comes from, right? Because we'd like to do this only once, so we need it to be concise and sensible, right? So I appreciate the questions. I don't have an answer about how the MCOs enroll with the groups.
I do.
Oh, thank you, Teresa. I was hoping you were here.
So typically the MCOs follow our enrollment. So And that's due to how we're reporting our network adequacy statewide. So I would hope that the intention is for them to follow the way that we're enrolling. There is currently right now some differences for certain provider types. But I think, Beth, we're going to be having a meeting with the MCOs. It's not scheduled yet, but the goal is to have a meeting with the MCOs next week. So maybe we add this to the list of things we talk about with them on that call.
Okay, thank you, Teresa.
Mhm.
And that is why your questions are important, because you think of things before before I think of things sometimes, and I don't know to get clear. If I don't see it, you guys do it. You guys are out there doing the work and performing the services, and I can't bring up and ask questions if I don't understand what the problems might be. And I think that goes across the board. So yes, I appreciate these kind of forums where you bring those questions up. It's helpful. Okay. All right, and then just to finish out then our presentation, my name is Beth Scott. I've provided my phone number. Email is the best way to get a hold of me. Many of you have my direct email address. That's okay. I put the behavioral health email address here just in case, God forbid, something happens and I'm not here tomorrow. That way you can still reach the entire team and it'll get routed to the right person. And so I think that's the better email address to use, but still, if you have my email address, if that's the one you're using and you reach out to me, that's okay too. Susan has provided her email address for any additional questions or assistance with enrollment, but my apologies. I feel like this was a little disjointed. This one was a little rough, and I apologize. I don't have anything to say other than to be in the uncomfortable silence. But this public workshop came out of, I think, this public workshop came out of concerns for the providers, and policy's goal was to get this to public hearing so that we could make the changes that made sense to the requests that our providers were asking us for the things that we could influence and make change on. So that's where all of the needs for clarification came from. So it's 2:52. Any final thoughts, comments, questions? I'm going to stop sharing my screen.
Hi, Beth, it's Susan. I just wanted to let everybody know that I just put my email address in the chat. So if you do have questions or need assistance with anything enrollment, claims, or prior authorization related, I would be happy to help.
Thank you, Susan. And I see that Teresa also dropped her email address in the chat. So if you have specific MCO problems from our call this morning, we know that there are plenty of them out there. Teresa has offered her email address to help start those, to help with those conversations and solutions. So if you don't have that, I encourage you to take that information down. Okay. Okay, thank you, Brandon. This was a lot of information for all of us today. As you go through and you process this, reach out to me if you think of something else, something that we forgot. My deadline to get this posted is the 20th. And so next week, so just giving that to you. So if you give me feedback, I can address it as long as we get it done by the 20th. All right. I'm going to give you back. Oh, sorry.
This is just Jennifer really quick. Oh, thank you, Angela. I want to pick your brain.
Oh, let's connect, girl. Let's go.
Thank you.
Thank you, Angela. Thank you, Jennifer. Okay, I'll give you back a few minutes of your afternoon then. Thank you so much, everyone, for joining us and bearing with us today.
Thank you,
All right.
Thank you,
Bye.
Beth.
Bye.